Thank you very much. Ladies and gentlemen, I'm truly honored to be standing before such a distinguished gathering of experts, scholars, practitioners, and leaders in this prestigious 10th National Summit of Health and Population Scientists in Nepal. Namaste and good afternoon. I am Kusum Sahi, and with a master's degree in public health, I have been serving in the Nepal Health Research Council since 2021, where I have been involved in various disciplines. To name some, nutrition and COVID-19. But in the past 2 years, I have been particularly engrossed in the study focusing on air pollution. This research has honed on the factors that influence childhood exposure to urban particulates. Well, now proceeding in our main protocol, that is, we are now finally reached to the final session of our day 2 of this summit. So let's delve into our session. So this session basically centers on developing a resilient health system to effectively combat HIV, tuberculosis, malaria, and COVID-19. Before we embark on our agenda for today, it is with great pleasure that I introduce our estimated chairs for this session. So our first chair is very honorable, our very respected Professor Dr. Janka Koirala. May I please request Dr. Janka Koirala, Professor, to please. Professor Koirala is a distinguished figure in the field of medicine and infectious diseases, currently serving as a professor of medicine and infectious diseases at the prestigious Patna Health Academy of Health Science in Lalitpur, Nepal. He holds a position as a clinical research consultant at the Nepal Health Research Council as well. It would be very much appropriate to acknowledge that his dedicated in health does not only limit to academic and research, as he is in Health Technology Assessment Committee at the Ministry of Health and Population in Nepal as well as Global Health Consultant for COVID-19. Furthermore, he is consultant for the World Health Organization and the Global Fund for Tuberculosis Nepal, providing expert guidance on disease control and prevention efforts on a global scale. Likewise, ladies and gentlemen, may I draw your attention for our next chair, who is Dr. Anil Karki. Please give him a round of applause. Dr. Karki similarly is a highly respected figure in the medical community, currently serving as the president of the Nepal Medical Association, a position that reflects his leadership and dedication to advancing healthcare in Nepal. With a focus on oncology, Dr. Karki serves as a senior consultant in head and neck oncology at the renowned BP Koirala Memorial Cancer Hospital in Bhaktapur. His expertise in his specialized field underscore his commitment to providing comprehensive care to patients battling cancer. A very warm welcome to both our chairs. Without further ado, I hand over the floor to our esteemed chairs, Professor Dr. Janka Koirala and Dr. Anil Karki, to guide us through this session. Chairs, the floor is yours. Thank you very much.
Thank you. Good afternoon, good evening, so feels like more like evening. But on behalf of my co-chair, Dr. Anil Karki, and myself, I'd like to welcome you all to this very important, and I'm sure it's also going to be interesting looking at the speakers lined up for this session. So this is going to be the session on resilient health system for combating HIV, TB, malaria, and COVID-19. So the speakers today who are going to present their I should say paper or presentation, they are all very experienced, and they have been doing this. They have been building the resilient health system in Nepal for a number of years. So it will be very nice to hear what has been done, what is being done, and what is the future in these 3 or 4 important diseases that afflicts a large population of Nepal. So since it's already late in the afternoon, without any further delay, I'd like to invite our first speaker of the day, Professor Dr. Ananda Ballabh Joshi. Dr. Joshi is a senior international public health professional and specialist from Nepal who has nearly 3 decades long engagement in the field of health policy strategies, research and innovation both in the country and international level, working with national governments, UN agencies and multilateral organizations. During his tenure with WHO, he provided high-level outcome-oriented strategic support to the developing and developed countries and periodically managed neglected tropical diseases, malaria, maternal child health, immunization, health emergency and disaster management program in the countries. Dr. Joshi currently serves as a director of Public Health and Infectious Disease Research Center, Kathmandu, Nepal, and responsible for managing team and priorities, promoting innovation and evidence-based results, and allocate resources for an office and field operation. So Dr. Joshi is going to talk on microstratification of visceral leishmaniasis, which is an important infectious disease in Nepal, in endemic areas to identify hotspots and disease shifting patterns in Nepal. Dr. Joshi, thank you very much.
Thank you, Mr. Chair. Mr. Chair, Co-Chair, I can see that distinguished participants here. Today my talk will be on visceral leishmaniasis, microstratification of visceral leishmaniasis endemic areas, and disease shifting pattern. So if you see that this disease, earlier 15-20 years back, it was endemic only 12-13 districts in the eastern Tarai of Nepal. But now you see that, the disease has been reported, more than 55 districts. The number of the cases has been significantly reduced, number of the cases. However, the disease has been spread nationally. Non-endemic areas are becoming endemic. Those they are severely endemic in the past 20-30 years, disease has been die out from that area and is shifting other. So we tried to have attempts to stratify the disease burden and the stratification. So basically this stratification is made to identify the risk areas. And this information, mostly the stratification made based on the available information from the Ministry of Health, Epidemiology, Disease Control Division, and the research done in a visceral leishmaniasis for last 5-6 years by the different organizations. And this microstratification basically based on the disease burden, what is the burden of the disease, and the receptivity that includes the environment which support the vectors, vector behaviors, and the dynamics. And thirdly is the vulnerability. Vulnerability mostly considered to be a movement of the population, rather we say that migration of the population. So based on these 3 criteria, we made the microstratification of the disease. These are the brief objectives of our this microstratification. We look the risk for VLs at the community level and see the spatial distribution of the disease in a communities. Then we identified the hot spots where at ward level where the disease has been reported, and also looked for the shifting pattern of the disease, how the disease has been shifted from the endemic areas to the non-endemic areas. endemic areas becoming disease-free and non-endemic areas becoming more potential for the infection, and disease is coming in a big way. And ultimately, lastly, we made some recommendations that what we should move for the next step for the elimination of a visceral leishmaniasis. And this is basically on the study design, where the micro-stratification exercise was done. Data were gathered from the ministry, from the different publications, researches done during the past 5 years. And this is the mapping, and then we'll have done the village level, stratification. This is the, we collected the base map, and we looked for the, altitude, temperature, housing structure, the vector distribution, the distribution of the sandflies, and the vulnerability, and ultimately the disease burden as well. Based on these, parameters, we stratify the disease, micro stratification of the disease was made. And then we gave some kind of a scoring. For an example here, disease burden, we gave a 0.5, receptivity, we give a 0.4, and in the receptivity, we have a percent of the sandflies, temperature, altitude, and housing condition. And the vulnerability, we give a very minimum, only 0.1. These are the different scores were given for the micro-stratification of the disease. And then, we consider that disease, present, the risk is high if the weightage is more than 4, more than 5, and if not present, the low risk there. So these are some of the receptivity criteria. For an example, altitude, temperature, housing structures, different weightages given for the micro stratification. Likewise, for the vectors, we give a little bit higher weightages. And these scores now, ultimately, if the score is more than 0.66, we risk level identified as a high risk, and 0.66 to 0.33 moderate risk, and less than 0.33 is a low risk. And these are the data we collected, from the different years. And if you look that here, we have done a stratification at ward level, and at this ward level, then you can see the list of the wards, those at high risk, moderate risk, and low risk. So these are the maps. Now you can see that disease distribution in a different years now. Now, for example, the first one